for this amazing conference. I felt so sad to hear that we're heading towards the finish line, because I'm finding this to be such an interesting conference, and I also feel I've enjoyed so much talking to so many people here. I'm going to miss you all. I think we've built a little community here among each other, and it's going to be a little sad when we disperse and go back to all of our separate lives and work. So today I'm talking about a new study design that we developed specifically for the purposes of, or the needs of, implementation research. And we call it the LAGO design, and it stands for Learn As You Go. And its purpose is to optimize complex, multi-component implementation strategy bundles, which is basically exactly what we're doing nearly all of the time in implementation research. And it's been very much a team effort. So you can see on this first slide a number of co-authors, both from Yale, Boston University, from the Infectious Disease Research Collaboration in Kampala, Uganda, and from Washington University School of Medicine in St. Louis. So what happens in a LAGO design is that the intervention is a package consisting of multiple components, and we've seen a number of examples of this in the talks over the past 2 days. And it can include a combination of treatments, a device, a care organization, and it could involve different components at the levels of multiple stakeholders. And so what happens is we start out with our initial package, and then we have pre-planned stages where we can actually change the package. That is, we can increase the dose of certain aspects of the package, we can move things in that hadn't been there, and we can strengthen and we can take things out if they're proving to be ineffective or cost ineffective even. And so we might have, say, 2 LAGO stages or 3 LAGO stages. Sometimes there's only 1 LAGO stage, which is still an improvement, and we analyze the data after each stage, and then we recommend how to adapt the implementation strategy bundle. So that happens often informally in implementation research, based on kind of people's subjective views and so forth. And as we've talked about even yesterday when we were doing, I think it was called the nominal, what was the name of the method? Nominal? Yeah, where we rank which barriers are the most important. Well, there are methods, there are approaches in that method to try to ensure that sort of the most powerful people don't dominate the conversation, because other people need to have a voice, and their views might even be more important in terms of the success of the overall program than the sort of most powerful people will hear, rather than, it's not a qualitative method, it's a quantitative method. And the data just tell us what's working and what's not working. So there's no discussion, it's just what the data are saying. Now, it can be, and another aspect of this is you don't have to listen to it. It's just a suggestion. You'll still have the important thing, like many of you who have had biostatistics, usually you would have been taught you can't change an intervention as a result of outcomes as the study is going along. But that's exactly what we're doing here. And now we've proven that it's statistically valid, that we can still test the null hypothesis, that there's no effect of the intervention strategy bundle overall at the end of the study, and still reject the null 5% of the time when the null hypothesis is true, which is what we mean by validity of a hypothesis test. And we also can optimize the intervention strategy component to ensure that we have adequate statistical power to do this test at the end. So it's very flexible in terms of what our goals are by the end of the research. So after, say, the first stage, we analyze the data. The intervention package is reconfigured based on the analysis. We roll out the revised intervention package, and we continue that process for, could be 1, 2, 3 times until the study is over. And then Like I said, we're trying to create the most effective intervention package while minimizing cost. And that's an important aspect because obviously effective in terms of, for any component that has a beneficial effect, the thing you want to do is just increase the dose to as large as possible. But that wouldn't be a good idea because that would be extremely expensive. So that's why we're balancing effectiveness with cost and trying to find an optimal package that both achieves the goals, say, of 80% hypertension control by the end of the study, with making sure that we spend the least amount of money to make that happen, given the tools we have in the package. So that's the basic idea, and we have, this is very new work. This is in part work in progress. So here is our primary publication. It's published in a very technical and prestigious statistics journal, the Annals of Statistics. So that's a very good thing because many people would think, oh my God, how can we change the intervention package while the study is going on? That we've always learned that that's like something you totally can't do. So yeah, we've shown mathematically using very advanced mathematical techniques that they're under circumstances which we lay out that this is possible. So this next slide kind of repeats what I just said on the first slide. Where am I going with this? Oh yeah, okay. And some other features that we've taken into account also are motivated by things we see in implementation research. So one is that oftentimes, as I talked about on Monday, our studies are cluster randomized. So of course we're taking into account that the study might involve a cluster design. And so that's an important feature. Another feature that is of interest is that it allows, the methodology allows for creating adaptations that could be specific to centers. So maybe there's an optimal package for peri-urban centers that's different than an optimal package for urban centers, and so on. So, and it also, you know, in terms of even the issue of equity and disparities, it might be that, say, the optimal package in a poorer area or facilities that are in a poorer area might be different than the optimal package where facilities are serving primarily higher socioeconomic status patients. So it allows for these complexities, but what I find in real life is that you can't make it too complicated. Like if you're doing one thing here, one thing there, and there's all these different components, it quickly becomes unmanageable. So even though theoretically, if that's something that really needs to be done, it can be done. It generally seems that the simpler approaches are what makes most sense in practice. Okay, so go on. And then, when the study is over, we get a number of very interesting outputs. So, of course, we get the test, the standard test of whether the intervention package as a whole is, you know, the null would be that there's no difference between that package as a whole, and whatever the control case situation was could be standard of care, or it could be comparing to some simpler, less intense package, but usually it's standard of care, compared to some new package of implementation strategies intended to address some health issue. So we get that p-value, of course, but we also get some extra things that you wouldn't normally get when you conduct an analysis. So one is that we get an estimate of the impact of each individual component. And that can be very important. For example, yesterday when Sten Vermond was going over the treatment as prevention trials and showing that you know, they were also complex. They were bundles of implementation strategies, many different or several different ways to prevent the transmission of HIV. And then when they, most of them didn't seem to really work, or just borderline, seem to, in this, you know, large effectiveness type public health setting, make much of a difference on HIV transmission rates. And Sten said, well, we don't really know, you know, what went wrong, because that was a pure pragmatic trial where they weren't really measuring how, to the extent to which the various components were delivered, where and to whom. And if that data had been available, we would know a lot more about what went wrong, and then we'd be able to design new packages that might address those issues. So you may have heard something about pragmatic trials, which tend to be pure effectiveness trials, and then they move into the hybrid design of type 1 hybrid designs where the focus is still on the health outcome, but data are collected on the implementation outcomes. And there's a way that the pragmatic trial world, the cost effectiveness world, is moving into the implementation research world by starting to collect data on implementation outcomes so we can understand both what is and isn't working with a particular intervention, and even if LAGO is brought into the picture, then we can also improve the intervention as it goes along. So we get data on the impact of the individual components, and is this right that I only have 8 minutes? What? Because it says 8:28. Oh, I see. Okay, thank you. And then we get an estimate of what the optimal intervention package is. And of course, this is from data. So we can say this is the recommended package. That's like saying this is the relative risk, the estimated relative risk. But we have confidence intervals around that too, because the estimated optimal package is a function of the data available in the study. And in a very small study, we have very wide confidence intervals around the acceptable packages that might achieve the goals. And if it's a big study, they might be very tight. We'd know a lot more about what the optimal package is. So it's important, as always, to take that uncertainty into account. I mentioned the p-value. And then we also get an estimate of both the point estimate, say, of with this optimal package, we expect to have 80% hypertension control, for example, with confidence intervals, say, of 75% to 85%, or whatever that is. So all of that uncertainty is taken into account. And from that point of view, the design and the methodology is, what we might call very rigorous from a statistical and methodologic point of view. So here I mentioned this first citation. We also have a second paper that's been submitted. It's available on the archive and can be downloaded. And then we also have a paper, we also have a paper, a non-technical paper, that's kind of a manuscript in progress, but I'd be happy to share that if people wanted to read that. That would probably make the most sense for most people here. So now I'm going to just move into an example because, like many of you may be like me, I learn best by examples. So this is a study that's going on right now that I'm a part of. I'm a statistician for it. There's a consortium that's funded by the U.S. National Institute of Health, National Heart, Lung, and Blood Institute, NHLBI we call it, where there are 6 countries in sub-Saharan Africa, and this is related even to another issue that we've been talking about here, that as the HIV epidemic becomes increasingly under control because of all these great ART and PrEP tools that we have, among other things, people with HIV all over the world are living much longer. And as I think Sten showed us yesterday, they're more likely to die from NCDs. This is HIV, long-term HIV positive patients are more likely to die of NCDs than they are of HIV and its corollaries itself. So there's interest in integrating NCD care into HIV clinics, and from what I understand, some of that's happening here as well. And so we're part of a study, a consortium where this is happening in 6 different countries, where each country is kind of choosing its approach for doing this. And of course there's a lot of overlap, but they're not identical. And then we're coming together and discussing common results and so forth. So I'm going to show some preliminary results from the Uganda group. So, and then it'll kind of also emphasize some other features, because as I said, like everybody wants to do step wedge designs, and we saw some yesterday as well in our lightning talks. And so this is a step wedge design, and there's, I think, 16 facilities that are a part of the study. And then the gray area is the control periods, standard of care, and then actually this is the light green is one intervention, we call it HTN Basic, where at the facilities we make sure that the facilities have the hypertension medications and the blood pressure measuring devices, but nothing else. And then HTN Plus is that plus training, audited feedback, and so forth, a lot of other coaching and different aspects to increase the comfort of the provider staff to talk to clients about preventing hypertension, screening for it, referring them to care, and making sure that they are compliant with their medication regimens. So this is sort of, a classic step wedge design, but what's new are the two black lines. Two black lines going down are where we're going to do the LAGO optimizations. So we're in the middle. One of them, I think, says July 2024. We're already, into August, but because it's taking a little bit longer. It's the first time we've actually ever really done it in real life, so we're still working on that optimization. And then we're going to do another one later in the fall. And so that's what the study looks like. And then there's a certain package, which I'll show you on the next slide, of the aspects that are being done to take care, to integrate hypertension care into these HIV/AIDS facilities. So the first thing, which in and of itself is very interesting, is in order to conduct LAGO, you have to collect data on these intervention components as you go along, because without that information, we can't figure out what's working and what's not working, and then see which doses we want to increase, decrease, and so forth. So what we have here on this busy slide is, these are the 7 components of this implementation strategy bundle that we're optimizing. One is access to antihypertensive medicines, the number of 1-month supplies dispensed to hypertensive patients in the past month. The next is access to blood pressure machines, the number of visits at which blood pressure is measured per patient seen in the past month. Then there's hypertension training, that's hours of training per provider on hypertension care across the entire cascade. Then there's 2 aspects of differentiated service delivery. One is instead of giving single-month prescriptions, giving 3-month prescriptions of antihypertensives, which is something that's already being done very widely for ART and the HIV medicines. And then the other differentiated care is to, instead of stable patients having to come into the facilities, that they're able to refill their medicines in the community. So that's another component that's being looked at. And then finally, and that's for the dispensation of the medicines. And then similarly, we have remote blood pressure monitoring to be measuring blood pressure in the community instead of having patients having to come in to get their blood pressure measured in the facility. And then finally, there's a performance improvement program that includes monthly audit and feedback, and then coaching and discussion related to the results, and that's hours per month per eligible provider. So we're collecting on a monthly basis the data in terms of the units that I just gave. And so we have overall, control period, run-in period, hypertension basic, which is just the blood pressure machines and the medicines, and then hypertension plus, which is everything. And you can see, for example, that only 3% of hypertensive patients were getting monthly supply of hypertensive medicines during the control period. But once the interventions rolled in, it came out to that patients were getting on average a 2-month supply of hypertension medicines. That's what we see here. And then we can see also that actually before the study even started, when we were in the control period already, 65% of patients were being screened for blood pressure. And then that has increased in hypertension basic and plus. So an issue was maybe the medicines weren't there, but the blood pressure machines were. And I think we've talked about this a little bit, I think in some of the other sessions, that there was some preliminary work done in Uganda before this big study went off the ground to assess the status of hypertension care in the facilities, and it was actually much lower. And I think staff and directors and so forth are sensitized to the importance of doing this because it is in the national guidelines. It's not a matter of a need for political advocacy. It's all kind of implementation issues that already their performance in this regard improved before we deliberately applied any interventions at all. So anyway, we have the data on the doses of these intervention components, and that's one of the inputs to the LAGO optimization. And then we also need the outcome data, so I actually have the outcome data here, but this is a randomized clinical trial with the DSMB, and so I'm not permitted to show you what the outcome data are, but I can tell you what it is conceptually. So conceptually, it's blood pressure control among all patients, and then blood pressure control under clinically hypertensive patients. And this is sort of a little side issue, but it comes up also in the HIV world. If we only looked at blood pressure control among the hypertensive patients, but there was very little screening taking place, what are we actually accomplishing? So from a public health point of view, actually, we have the definition of blood pressure control means having been screened and not being hypertensive. And if somebody came in and they weren't even screened, we're counting them as out of blood pressure control because we don't really know. We can't really treat them. It's the same thing with HIV screening and then referring people to care. Well, if you only count those who were tested, and then you look at, what about the huge pool of people that we never even reached to test? So the statistics can be misleading. And there's sort of more public health and more clinical ways of looking at some of these issues. So then, here's the data that would have been so great to have had in the treatment and prevention trials. Once we have this outcome data and these measured component doses repeatedly over time in the different facilities, we can run a standard logistic regression where the variable is percent of patients under hypertension control at each facility in each month, and then the predictor variables are the doses of the components. And then we can estimate the effect of all of the components. So what we see here is, among all patients, say the odds ratio is 1.23, meaning there's like a 23% greater odds of the patient population being in hypertension control for every additional 1 month supply of medicines prescribed. And then when we say access to blood pressure machines, 2.5 higher odds of being in hypertension control for every patient who's measured, every additional patient who's measured, whose blood pressure is measured at the visit, and so on. And so you can see this is a very big study, so there's almost 200,000 patients already, even just up to this first optimization in these 16 large facilities, of whom about 16,000 are hypertensive. So you can see that most of these effects are significant, and in addition to looking at the significance, we're looking at the strength of the associations. But very, very good data. And something we're seeing is very little impact of the multi-month method for prescribing the medicines, but strong impact among the hypertensive patients for community-based drug distribution, and so on. So these are the estimates, and so something we've learned actually is it's challenging to analyze these data. These are complicated data, and a PhD student could spend a year of their PhD dissertation analyzing these data, considering different models, considering ways of parameterizing these different intervention components, taking lag functions into account, and so forth. And so we're still trying to stabilize the analysis. This is what I call preliminary analysis, to give you an idea of the kind of information that we get when we conduct a LAGO study, and then how it's used. And then, as I mentioned, so just to say, so let's say, okay, we're seeing very strong effect of measuring everybody's blood pressure every month. So you say, okay, well, let's just do that. Well, what if it was expensive? It actually isn't, so it's going to turn out to be something that's highly favored. But another aspect of data we need that is more challenging than we might have originally thought, is that we need unit costs of each one of these intervention components. It has to be costed out, just like if you were a clinic director and you were figuring out the budget for your facility. But these numbers aren't necessarily known in advance. This consortium has a team of health economists working with their counterparts in the different countries, and slowly, we're getting estimated unit costs for these different components. But the health economists take this sort of costing very seriously, and it's not something they can just go in one day and say, oh, it's 50 cents a 1 month supply, and so on. So what I have in yellow here are, these were empirical estimates we got from the costing team, and as you can see, this is in US dollars, so it's like 14 cents per blood pressure measurement, and that takes into account the long-term cost of the blood pressure machines, plus the cost of the provider, the time that it takes the provider to do the measurement and record it in the system. And whereas a 1 month supply of antihypertensive medicine is $1.20. And so on, and then doing things in the community and so forth, they have different costs. And let's say an hour of participation in a performance improvement program is estimated to cost around $5, and that's averaged over the hourly wages of physicians, nurses, and lower level health providers, as well as the trainer or coach who's leading the session. So we have these cost data, and then we have a cost function, which I'll skip, but what you have to do is average the total cost. To create the total cost of the whole package, you have to multiply the dose times the unit cost and sum those up. That's what that previous slide says. And then we also have this function, which we're taking account here, that health economists feel that there's often an economy of scale. So when you're doing a lot of something, it's often cheaper than when you do a small amount. So these are three different functions that consider economy of scale, and the green one, which you can see the cost just goes down a little bit over the wider range, over the higher dose range of this particular component, which is access to antihypertensive medicines. And then we have kind of an upper bound with the idea that you can't just go to like an infinite number of whatever there's a certain limit to what a facility can handle, that providers are available, and so forth. And so then, because we need or want these cost functions, we don't know them. We have to assess the sensitivity of the recommended optimization to different assumptions about the extent to which there might be an economy of scale. And then finally, here's the punchline. So here is, given what I just showed you, those unit costs, those estimated component effects of the components, and so forth, we get a recommended optimization. And so what it's saying to do is it's basically saying that the recommended, we should give on average 2.5 month supplies to hypertensive patients. That's what, here it says 2.454. And what we had previously been doing in Hypertension Plus, the most intense implementation strategy bundle we're studying was around 2. So it's kind of like do better, try to get out more monthly supplies to people. Then measuring blood pressure for patients coming in, about 84% were getting it. It's saying increase to 100, try to get everybody. Then the number of training per provider, the average was about 0.6 hours per month, and it's saying increase that to 3.5. So I think somebody had said, I think it was Rick maybe showed us that there's systematic reviews of these different types of implementation strategies and whether they were effective, and training has been shown not to be very effective, but we're finding it to be extremely effective here, to the point where 3.5 isn't even realistic. I don't think we can do 3.5 hours of training per month in these facilities. That wouldn't be sustainable. And so what we have to do is lower the bound, that the upper bound can't be 3.5. We have to talk more to our colleagues and say, well, could you do 2 hours per month? Is it really 1 hour a month really realistic? And that would be the upper bound, and we can see we'll hit the upper bound because training has been found to be really effective here. And then so on. So the proportion of drugs dispensed as multi-month, it's actually saying 0. That's not really working very well. It's not having much of an impact. Similarly, the community-based, we had been doing about 30% distribution. It's saying that isn't really that effective. Even though it should be less costly, it's actually suggesting to lower that. And so on. So this is the optimal package. And again, like I said, we don't have to follow it, but it gives some guidelines to maybe what directions the study should go in terms of which aspects seem to be really important and are going to really get us to our goal, and which ones maybe aren't as important. So some of these differentiated service components don't seem to be having much of an impact, whereas training and then also the audit and feedback also is being suggested to be very effective. So that would be something that would be continued, but maybe not focusing as much on the differentiated service delivery. And then at the end, we get a total cost for all the facilities per month. If we did all of these things at this dose, and it comes out to be about $16,000 per month. And then that would get us to 80% hypertension control among all patients and 45% hypertension control among hypertensive patients. Now you might say 45% is a low bar, but we're starting at something like 8%. So it's a huge increase. And maybe we, if we were to continue, say, learning healthcare system capacity, we could continue to try to improve the intervention and get the rate of hypertension control among the hypertensive patients even higher. So that gives you an idea of what happens with LAGO. And yeah, so I actually have a little bit of time left, which is nice, and maybe you all have some questions. Thanks very much. Yes.
Hi, good morning, Donna. Thanks very much. It's the first time I'm hearing about LAGO, as a lot of things I heard in this bootcamp. So Aisha from Cancer Research. My question is that when I look at the study design and the data that we're looking at, I'm just wondering about the confounding factors. Because I could see that there are multiple rounds of process evaluation and also optimization. So I'm just wondering if that's the role of that multiple process evaluation and optimization. Is it to address how we're going to deal with the confounding factors for the data analysis in the end? Because there are multiple components in the intervention itself. Basically how do we ensure that the result that we get is not due to confounding factors? Thank you.
Yes, that's a great question. And so there's two aspects of the analysis. The first is the standard analysis, which let's see if I can get back to the step wedge. I don't know if I'm the wrong way. The step wedge, oh, here we are. Where's the step wedge design? I'm still going the wrong way. Sorry. When we go to the step wedge design, maybe I'm not going to be able to find it. All right, forget that. So the test of does the null hypothesis, does hypertension basic, the null would be hypertension basic has no impact on hypertension control in all patients, and then we have two primary hypotheses, and then among hypertensive patients. So that is the pure step wedge design. Nothing was changed to the extent that the patterns that the facilities were rolled in to start hypertension basic or hypertension plus still has those full randomization features, and then the within facility comparisons have the quasi-experimental before-after features. So, technically there should be no more confounding than in a standard step wedge design, because all that's happened internally is that the package has been altered. But the fact that they were randomized to one package or the other, that was already a randomized design feature. So, you can have residual confounding in cluster randomized designs because you only have, say, 8 facilities that are in hypertension basic or hypertension plus compared to the control facilities. But it's a randomized comparison, so we don't have to worry about confounding technically, at least in the primary analysis, and we can do secondary analysis to control for facility level features to see whether they change the results in any way. But the thing that you bring up where there is more of a concern is this issue of estimating the impact of the individual components, because how are we able to estimate those? We're able to estimate those because, I don't know why I can't get out of this. Oh, there we go. Because as you can see from this graph, that there's variation from month to month. Like we have a protocol and they're supposed to do something. Let's say measure blood pressure in all patients that come in, but that isn't happening. In 1 month it might be 80%, the next month 83%, the next month 70%. So we're assuming that those variations are random and they're not due to knowledge of the facility level performance. And that's where you could actually have confounding. So it would, another further work that we could do is to take into account methods to adjust for confounding in the estimates of the impact of the individual components, which then determines the optimization. But it doesn't affect your interpretation of your overall study results. It would just mean if these impact estimates are confounded to some extent, it would mean that we're not going to get the absolute perfect, optimal, optimized intervention package at that stage. It might be off a little bit due to confounding one way or another. But it's probably still going to be a lot better than continuing to do the same thing that was done at the beginning, before we had any knowledge of what was working and not what wasn't working. But we may not have the exact optimization, and we could do more research, even just sensitivity analysis. Suppose there was this much confounding of some of these estimates. How far off would the recommended optimization be due to confounding? Does that answer your question? Okay. Yes?
Thank you very much for that interesting concept of LAGO. Just going to ask you 2 questions, basically. Because usually when you talk about trial, we need to register our trial before we can start it. But yours is basically you move along and then you change it to fit it. Then people say that you are not doing what you want to do, but you're just doing because the situation changes. So that's the first question. How do you actually answer that to the people that you review it, right? And the second thing you mentioned about you change different component in different setting. That would affect the sample size, and how actually you estimate the sample size in that context. Then the sample size will affect the power of the study at the end of the day. So how do you consider that? Thank you very much.
So of course that's the most important question, and this is exactly this top citation is where what proves mathematically that making these LAGO changes doesn't affect the power of the study. It doesn't affect, well, it can affect the power of the study because, sorry, let me take it back. What we proved in this first paper is that we have the correct type 1 error rate for the study, even when conducting LAGO. So we're not going to reject the null more often because we've done LAGO when there's no effect of the overall package. We're going to reject it exactly the 5% time, and that's what was proved in this paper. So we do have now, I think, 3 different studies that are registered in clinicaltrials.gov that are using LAGO. They were in the grant applications, and now they're in the registered protocol. It's been reviewed by the DSMB, and this paper is the source for showing that you have a valid test of the null hypothesis, which is how you power studies. You power studies around, given that you have the correct 5% error rate when under the null, can we maximize the power when the null isn't true? And so we retain that 5% error rate, but like I said, one of the optimization criteria can be to improve the power, and that is a wonderful thing to be able to do. because there's many examples, including these treatment as prevention trials that we heard about yesterday, where the trials, quote, failed, they were considered negative because they didn't have enough power. And it turned out that the intervention wasn't strong enough to get the desired effect. And what we saw in treatment as prevention was there was a failure to link people into care, and then therefore they weren't getting their ART, and then they were still continuing to affect people. Well, if LAGO was going on, we would have been measuring that as an implementation outcome. We would have seen that that was going on, and then we would have introduced additional implementation strategies and strengthened the existing ones to make sure we were linking more patients into care so that we would get the effect needed to reject the null when it wasn't true, and they wouldn't have been, quote, failed trials. And I think you asked something else, but I don't remember what it was.
Basically on the thing, you say you register the trial as LAGO. What happens if you don't register the trial as LAGO and then at the end you want to change it?
You can't. You have to do LAGO while it's happening. Because that's the whole idea here.
So
you can do it, like, see where the two black lines are for this study. So I just showed you the recommended optimizations. So it's like really try to measure everybody's blood pressure. The trainings are really important. The performance evaluations are really important. Don't, maybe don't worry so much about differentiated care. It really isn't having much of an impact. So use your resources for the things that are really working, and that way we'll get to 80% hypertension control at the end of the study.
So the question is, that means you can't, let's say I have an ongoing trial, I can't change it because it is not a LAGO design.
Oh, you mean if you already have a study and you wanted to add LAGO in?
Yes, so how does that happen?
Well, it hasn't come up yet because this is so new. I don't see why you couldn't do that, because it doesn't affect your type 1 error rate. It's like going on under the hood. You're changing. We still have hypertension basic. We still have hypertension plus, but what it is different. It's evolving. And in fact, as many people here probably know who are actually doing implementation research, everybody's adapting their interventions anyway, all the time. It's not like anyone's sticking to what was written in the protocol when the grant was submitted, because people are informally learning as they go. And so this is a way of formalizing what's happening anyway in real life.
Thank you.
Sten, did you have a question? I saw your hand up at one point.
Donna, this is absolutely fascinating for all the reasons you articulated. I was curious about the finding of owning the blood pressure cuff or machine. We all believe in behavioral feedback, and if one can actually measure one's blood pressure, one feels empowered, one recognizes when one is in good control, not good control. There seems to be an intuitive value to having hundreds of thousands of people have what we upper middle class people take for granted. And your effect size was dramatic, 2.5 I recall, and there it is. And then you found it to be reasonably cost effective. What is the next step in the study for provision of these machines? Because the costs have dropped considerably, and I think they are now much more in the realm of public health efficiency. After all, you buy one machine that lasts for many years. What is the thinking of your team in access to blood pressure machines?
Yeah, so there's a little bit of a misunderstanding because this component is not in any of this study or any of the other 5 countries who are looking at this. It's not about giving people their own blood pressure machines to take home like that. I think it's just like way off the charts in terms of feasibility at this point in time. This is just simply having the machines in the facilities or having a station in the villages or a mobile truck going around.
Even that is is very important information because, you know, not having a clinic or mobile facility that can't measure blood pressure is really an indictment.
Yeah, so having it in the facility seems to be really important, and the study, you know, has had a big impact on improving the outcome. But surprisingly to us, we're not seeing the thing that you said, it was intuitive, that other, especially investigators from the United States, that, you know, that we're all moving towards giving everybody a blood pressure cup. But even the community-based distribution models and measurement models don't seem to be having much of an impact. That's what the data are saying, you know, in this setting. Now further, you know, we've talked about LAGO, where once we see something like that, and among the study team, we've talked about it, doing some qualitative research to find out what's going on when you have a surprising finding. Like, you know, to talk to both providers, the people who are out there doing this in the community to find out what's really going on, and then to talk to patients who either were or weren't measured to understand more about what's going on, and then maybe that can be further improved. Or maybe it just is better for people to get into the facilities and have their blood pressures measured at this point in time. And they are HIV patients, so they're coming in every 3 months for ARV anyway. Great. Well, thank you all so much.